Before we start the episode, I'd like to apologize to our listeners. While recording, we experienced some pretty significant audio distortion at times, and unfortunately, any ability to remove it or edit it was going to change the context or the meaning of the comments. So I apologize. Hopefully you can bear through it. There's still some good stuff in there, and so we still wanted to push out the episode. Thanks again. Hello and welcome to episode 6 of Get Hydrated, the podcast about the people of healthcare. Our guest today is Aren Morris. With more than a decade of experience in pediatric nursing, she provides valuable perspective for the front lines of healthcare and probably more specifically patient care. Recently, she returned to specialty group practice as a pediatric cardiology nurse after leading the clinical team of a Texas home health agency. And then previously, she actually worked at a top-ranked Texas pediatric hospital as a clinical leader and RN. I'm excited to welcome the epitome of our model guest, Aren Morris. Aren, how are you today?
I'm good. How are you?
I'm good. Thank you. Well, thanks for taking time out of your day and joining us here on the podcast. As I said, I think your firsthand experience and being in a clinical role can be very valuable to lending perspective to those who listen. So thanks again.
Sure. Thanks for having me.
Absolutely. So what I want to do is first kind of talk more specifically about some of your firsthand experiences as both a patient care provider as well as some of the leadership roles you've taken on. And then we'll probably expand that a little bit more about the healthcare industry as a whole, some of the changes and challenges you've seen, and then we'll close talking about patient care / kind of communicating with patients questions at the end, and then we'll go from there. How does that sound?
Sounds good.
All right, great. So, Aren, you have, as we mentioned, spent some time in an acute care setting previously, went into a director role in a home health setting, and then now have made your way back into more of a kind of an ambulatory setting in a physician practice. Could you talk to me a little bit about some of the big differences you see or challenges maybe you see between the differences in being in an acute care setting versus home health?
Yeah, absolutely. They're very different. I feel like I've had a very well-rounded career, both in an acute setting and in home care. And I think it's good for anybody, any nurse working anywhere, to see both sides of things. Working in the hospital as a bedside nurse and then as a case manager, there's a lot of negative connotations to home health. They don't see it they just look down upon it. And I can see where they're coming from, but also being on the home health side, there's a lot of great things that are going on there. There are a lot of great nurses. There are, I had it in my mind that what we were doing in home care, doing home private duty nursing, was keeping these families together and out of the hospital. And so that was, in the hospital, your goal as a nurse is to keep these patients alive. And I guess that's your goal at home too, but you're also trying to help keep these families together at home and allowing that all members of their family to play a role in their family. So the biggest difference is, in the hospital, I was surrounded by nurses. All I did was work with nurses. In home setting, especially in a director role, I was the only nurse in the office. And so that was interesting because that was just a big, huge change for me. And then the nurses that I was working with in home care were very different than the nurses I was used to working with in the hospital at the bedside. In the hospital, I was used to working with RNs, usually for the most part had a bachelor's degree, had a BSN. There were a lot of nurse practitioners that I was working with. The management all had master's degrees. And so the level of professionalism that you see from nurses in a hospital setting are very different than the professional level of professionalism you see from home health nurses, particularly the LVNs. For the most part, most hospitals these days don't hire LVNs anymore. And so the only place for LVNs these days is either in a home care setting or a nursing home setting. There were some RNs that work home health, are some RNs that work home health, but you sometimes have to wonder why they're working home health when they could be making so much more money working in an acute setting, either in a hospital or a clinic. So, and a lot of times the reason is they just need more flexibility in their schedule, but sometimes it's just they couldn't hang with the RNs in a hospital. They just didn't fit in for whatever reason, or couldn't keep up. So, those are kind of the biggest differences, was the type of nurse that I was working with in the different settings.
Yeah, that makes a lot of sense. What do you think are the skills that are required for a nurse to be successful in a home health setting versus acute care setting? I assume, kind of based on what you're describing there, at some level there's probably some different strengths and or weaknesses that allow you to be successful in what are obviously very different environments. Are there things that you think you can pinpoint to say that this type of skill set's better suited here versus there?
Well, the first thing that comes to mind is home health nurses are on an island when they're in these homes. And to me, home health nurses should be the ones that come with the most experience and that come with a lot of great problem solving skills and autonomous thinking. And while you want that in the hospital setting as well, again, you're surrounded by other nurses. If you need help, you can just call out and you've got 3 or 4 nurses running to help. But in the home, you're on your own. And I really feel like those nurses should have the most experience, especially in the home, because home nursing is very different than bedside nursing. You're doing everything for that patient. You're working the ventilator, you're giving the breathing treatments, you're giving the bath, you're changing the diapers, you're giving the feed, you're giving the meds, you're doing everything. Whereas in the hospital, those are broken up into different roles. The respiratory therapist is taking care of all the breathing stuff with the ventilators and the breathing treatments, and the nurse gives the meds and the feeds, and maybe there's a patient care tech that helps with the bath and the diapers. And, most of the home health nurses, I've found, not most of them, but a lot of them, they'll come fresh out of LVN school and go straight to take care of a total care ventilator patient when they have no experience. And that is scary.
Sure. Yeah. And, it's a bit of a catch-22, obviously, in that part of that reason that probably drives that is it's that, ironically, kind of to your point, that it's become the industry standard that's kind of the environment that those nurses go to, but also, obviously the pay grade in home health is lower, right? And so, new grads, who kind of, as you alluded to earlier, maybe need some flexibility and or maybe on the back end perhaps of their career where they don't want to be running around a med-surg floor in a hospital or something of that nature, that home health environment becomes more conducive to them. But, because of I think the probably inaccurately described in some ways, slower pace there, right? You're not running from 3 or 4 patients. You're obviously just with one, but right. Again, to your point, you have the situation where the care and time needed perhaps with that patient is you being on an island and there is no one to turn to. So that's very much an interesting dynamic that you point out there, because I think it's real easy to make some assumptions about why nurses are in home health or what type of nurse, quote unquote, belongs in home health, but then quickly make a case for what should be the complete opposite, essentially.
Right.
So, you can expand beyond just, this specific consideration of the type of nurse that may fit in with home health versus fitting in with an acute care setting. But, do you feel like there are things that a company can do or just in general in the industry to maybe kind of shift that approach? I mean, obviously, it's a very tall task to try to talk about changing out skill sets, right, and flipping them. But as far as adjusting the the expectations, I guess, maybe along the way to improve the, both settings for that matter, do you think that the things companies can do and or what you would like to see done in the industry?
Sure. The first thing that comes to mind as far as home health, one thing that's so great in hospital setting is the training. So a new grad comes out of school and they go through several months of training. They have preceptors and they go to classes and they do skills labs, and it costs a ton of money to train a new grad nurse at a hospital, especially depending on what area. Like if it's an ICU nurse, that's even more. But a home health nurse will come right out of school and go right to the bedside. And there's a lot of limitations to training in a home health setting. They're just, Medicaid doesn't reimburse for that. So any type of training of these nurses would come right out of the company's pocket. And it would have to be an investment in their staff. And it's hard to, because I tried to do this some in my previous role as a director. No parent wants to, you would have to call and ask permission for a brand new nurse to come and train on a parent's baby.
Right.
And that's a hard thing to sell sometimes.
Nobody wants to be the guinea pig for the new nurse, right?
Right. And it's easier to do that in a hospital setting because nursing students or new nurses, they come and go, or they're right there with their preceptor. They don't really have a choice in the hospital setting. In the home setting, you have to ask permission to bring a new person into their home. And so it's hard. I know some of the bigger companies are able to provide training. They'll bring in respiratory therapists to do ventilator training or trach training, which is great. But it's one thing to sit through a 2-3 hour class and maybe get some hands-on training with like a doll and some traits that they have laying around. It's another to do this on a real person. And so, so that I think that's one of a challenge in flipping and making sure that the home nurses have the most experience and are ready to be on an island. I think too, I've noticed too that quite a few LVNs, they'll start work as an LVN in the home care setting, and then they go on to get their RN and they move on. And so you don't see too many nurses that have been in home setting. And correct me if you've seen something different, but for the most part, the nurses that I was dealing with, they've been doing it for a few years, but not like many like you would see in a hospital setting. So I don't know. It's just.
No, that's true. It is. I mean, whether anybody wants to hear it or not, there is one thing that certainly can be said, and it's not good or bad either way, that there is without question a significant difference between nurses that work in an acute care setting and those in a home health setting or a post-acute setting. There's just no ifs, ands, or buts about it. And again, we don't have to get into the good or bad or who's better. It's just there's a host of traits that you can see the differences in. So I would agree with that 100% in my own experience. And so, yeah, there's without question situations in both environments that create major challenges. And you know, you touched on the professionalism, and we don't necessarily need to elaborate on that, but when you were talking about the companies needing to invest in these nurses for the training, some of the larger companies, as you mentioned, can do that because obviously the affordability is a little better there. But at the same time, even for those large organizations, there tends to be a hesitancy to go above and beyond because what you kind of just mentioned, even in a short-term career for somebody who's in home health, they're probably working at 2 or 3 or 4 different agencies, and you never really know how many hours that nurse may end up working for you because, for one, they're looking for that flexibility. So they employed at 2 separate agencies, 3 separate agencies at one time. No company wants to pay for this nurse to get their vent certification to go work at another place, right? So
right, and that happened. Like, I would have nurses come in to get hired, and I would ask about their ventilator experience, and they said, "Well, I went over to this company and got my certification or took this class, but I never worked with them. But I'll do it with you." So, like, that company paid money to train that nurse, but now she's coming over here to work for another company with that training.
Yeah. There's a very, even in the individual nurses themselves, both sets of nurses enter into those 2 environments knowing what to expect too. And what I mean by that is like, no nurse goes to work at a hospital and thinks they're going to take the skills that they learned during the first 3 months and go get a new job, right?
Right.
There's a sense of loyalty going into that environment almost right out of the gate, right? And the hospital created that either through the interview process or, job description or the staff, case managers, department managers, whoever it may be, that it's a very different dynamic where, you can, to your point, have a nurse sit in front of their director at a home health agency and say to them, "Oh, I got that certification or that experience at another agency, but I'm willing to bring it here." So in so many ways, basically saying to you, "I'll do this to you too if I get the right opportunity."
Oh, 100%.
Yeah. So definitely, creates an interesting dynamic for everybody involved. Expanding kind of beyond some of the more specifics and thinking about the industry as a whole, right? We've talked about some perspective on our end, but maybe kind of put yourself back in your shoes of even now, right? You're back more into patient care directly at your physician group. As a clinician, you look how the industry's changed. You see changes that are coming. What types of things are important to you now as a nurse as you look at maybe taking a new role in the future, or maybe even something you considered in the role you've taken on now? What things are important?
Well, it's more, so when I first started as a nurse, it was more important for me to have the quote unquote cool job. It's like, I needed that adrenaline rush. So I worked in the ICU, and after a couple of years realized that maybe I wasn't really cut out for that after all. I started to realize that it was more about the types of patients I was taking care of, the setting I was taking care of them in, and the people I was doing it with. So now when I am looking or thinking about another job, or I first think about the patient population. Like, I particularly love taking care of kids who are chronically ill. I've done that in the pediatric cardiology population. I've done that in the pulmonology population, cystic fibrosis patients and ventilator patients. And then obviously the home care patient population is a chronic patient. So I love that because you really get to know the patients and their families. And then I look at who I'm going to be doing it with, the people I'm going to be working with. Are they do they have a good reputation? Do I know who they are? Have I worked with them before? Has anybody else I've worked with them before? Does it seem like I would fit in with the culture of that company? And then the setting, I guess, I've done home health, I've done hospital, I've done now ambulatory care. That doesn't necessarily matter to me as much, I guess, anymore. I loved my time in home health. It provided a lot of flexibility for me. And it's to me, it's really more the type of patient and who I'm working with is what I'm looking for.
Yeah, I think like most things in life, right? Once you
Right.
a little bit more, you don't know what you don't know, but then you kind of get an understanding. You understand what's different and important.
Right. Right.
I think back when you mentioned about how you started off in the ICU, and then certainly after maybe transitioning and spending some time in some other settings, realizing that more of that chronic patient is better suited to your personality and what you enjoy. And I think about my time in my early career in this one particular ICU RN who worked for us, and I was young and naive myself out of college. I had a healthcare background, but from more of an academic environment, obviously, as in a health science degree, and so not really clinically speaking, but this stuff was very new and foreign to me, and she's kind of the perfect example of what you're describing, where in an ICU environment, obviously, due to the nature of the patient and the acuity of the patient, that patient obviously can code and pass away at any time. Now, of course, that same thing can happen in home health, but I think that the difference is in the ICU environment that happens, it's kind of on to the next, right? You can't, and you almost have to be kind of that brazen personality a little bit that you see sometimes in physicians, and that, that's part of the role is that if you got connected to every patient, you wouldn't last long, because the reality is that they may pass and you can't feel that connected to everybody. So it jumps out to me that you say, you see the difference in what your fit was. And right away I knew that, with this nurse in particular, her brazen attitude didn't fit well.
Right. Yeah.
The parent and or guardian of that patient is looking for somebody to be compassionate, and just can't wait to get out of the door because she thinks she needs to go take care of another patient. She's going to check in the other bedroom to see if there's a patient in there.
Yeah.
Couple. So speaking of kind of that communication with patients' families and or patients in a time of maybe understanding their kind of new normal, if you will, or even kind of the diagnosis of that patient and what to expect going forward. Do you have any advice or thoughts about how do you have kind of those tough conversations with those patients or families? I think if you want to elaborate on both settings, you can, or if you think it just in summary, give us an idea of the best way to handle those.
Yeah, I think it's the same in whatever setting you're in. At least for me, I've always found that being as direct and as and providing as many facts and trying to be as objective as possible it is always the best. It's not always the easiest. You don't want to give patients and their families false hope. You can give them hope of peace and comfort, but not necessarily hope that their family member might, like, hope for a miracle, I guess. It's a fine balance between being direct and providing this information to them that is hard to hear, but also doing it in a compassionate way and still being there for them, being a support for them. It's a fine balance, and it's something that comes with time and experience as in the healthcare field, or not. I know lots of nurses and doctors who aren't good at that. So then you end up swooping in and trying to take over. But it's hard not to give them glimpses of hope here and there, but you have to be careful with what you say in these situations. Patients and their families will take anything that you say and run with it. Oh, well, you said maybe he might take a breath on his own. Like maybe is that a possibility? Like, and so you have to be, when you fully well know that that's not ever going to happen. The patient's never going to take a breath on their own, but you have to be very careful. And it's hard to, when you work in a hospital setting, you work in a home health setting, you're not the only provider usually for that patient. And so you might be coming on after a provider, a nurse, or somebody who has been giving them false hope the whole shift before. And now you're coming in and you don't want to come across as the bad guy, but you also don't anyway. It's a fine line. It comes with, comes with time and experience. But I've always found that being direct and providing facts, and sometimes you just have to repeat yourself over and over again, the same things, because until they hear it, because they're going to pick and choose what they hear and hold on to any glimmer of hope that they can find. But you just have to repeat yourself, being as direct as possible.
Yeah, and let's be real. It's human nature that in a time of emotion, it's harder than ever to listen and just really hear what's being said. And so even those with the best of intentions about hearing what the clinician or the nurse or, the physician may be saying to them, it's easier said than done, right? If it's in a very emotional setting. So, to patients and or guardians that may be listening to the episode, that's something for you to think about as well, is that you have responsibility in that conversation, in that meeting, to be listening and be aware of your emotions. And it's, of course, to have them, but it's important that you are attentive about what's actually being said. So you're not giving yourself false hope or creating a difficult situation for another nurse or yourself further down the line. So yeah, it's needless to say, a tough time, and it can't be easy to have that conversation for anybody. But facts always seem to lend themselves to the best results, especially when the interpretation can go sideways if you're not careful. So that makes a lot of sense.
Yeah.
Kind of in closing here, one of the things I wanted to touch on that's still tied in with patient care, but also maybe has a larger component to it as well. Being in the Texas market, coming from home health, which, as I've said on this podcast before, part of my background as well, and specifically worked in the Texas market. We've heard a lot about the Texas Medicaid transition and MCO environment that's now been created in the state of Texas. This could be clinically or non-clinically speaking, or both. Look at patient care. What are the things that stick out to you that you feel like really inhibit either your ability, the nurse's ability, or the company's ability to provide quality patient care?
The first thing that comes to mind is the reimbursement rates. We talked about the professionalism and the lack of experience in the home health nurses. That's because once they get experience, they can go work somewhere else and paid a whole lot more. Medicaid is just not reimbursing enough to pay. A lot of these nurses are single moms. They're supporting their families, and they're not maybe making $22, $25 an hour. And for a lot of them, for what they are going through, taking care of some of these families and the environments in which they're taking care of them, they deserve a lot more. And it's hard to find quality staff when you can't pay them very much. One thing too with the changeover from traditional Medicaid to the MCOs, and it didn't happen as quickly as I thought it would, but it did happen eventually, was they started slashing hours and taking hours away from kids that had maybe had those hours for years. Like nothing had changed. The patient had been trucking along with the same nurses, the same 60 hours or whatever a week for years. And then all of a sudden they come around, they've got this new MCO, and they decide that they don't need those hours anymore. So that's a huge upset to those families, the nurses, but especially the patients. They're not, now they're going to get slashed their care, and so they're not getting the consistent care that they were getting previously. Maybe now they've lost their nurse that they've had for years because she wants to get the same number of hours, but she can't with this kid anymore, so she's going to go over here. So it's just, that was a huge frustration. Kind of happened about a year after the change. So that was a big thing. And then, and it doesn't, not necessarily home care, but, just hearing stories of other things not getting approved, therapies, medications, other treatments that were previously approved, but now they're not getting, and the families, it's basically a full-time job sometimes for these families to fight for what they need, because they, of course, the hours would get slashed, or the hours would get denied. And then it's a whole process to appeal that denial after the fact. And, I tried in my role as a director, I wanted to take that stress off of the families. That was something I could do for them, to help alleviate that stress, but I could only do so much. I mean, it has to be initiated from the family. They have to be available, like the fair hearing, they have to be available for the hearing. They have to do some of the legwork, sometimes collecting letters of medical necessity from different physicians. And so, you want the families you want these parents to have lives and to work, have jobs, and they can't do that if the hours get slashed for their child who can't go to daycare or have any other kind of child care. And they can't do that if they're spending all their time fighting the MCOs.
Right. Well, and, even if it's just cutting a 4-hour window out, for those who listen to the episodes previously, I've talked about the Dallas Morning News pain and profit story, where this area very much hits on exactly what Aren is referring to about kind of out of nowhere, for seemingly no real justifiable reason. Deshaun Morris, the child in the story's hours were cut. And as Aren alluded to, it's one piece to think about the things the family has to go through in order to kind of fight that battle to, file an appeal or whatever it may be. But also, if it's a 4-hour window that gets cut, the likelihood that you're able to find staff to make those adjustments, for 10 hours a week, you may end up losing a nurse entirely. And so the fallout from what may appear from the behind the desk, a simple decision, has some really significant effect in a lot of ways and just changing the environment as a whole. And so the Dallas Morning News story obviously talks at length about that. And the one thing I want to include too is, I've talked about in a previous episode, is you talk about the MCOs and the changes that occurred about a year in. And for those who don't know, the easiest way to describe the MCO model would be this, where you have previously, you would have had a service provided by a clinician, and the provider, i.e. the company in this case, bills the insurance payer for that service. So there's a direct A to B correlation there. In a MCO model or environment, what happens is that there has been essentially a head rate or a per member rate established in the contractual negotiations, that they're going to get paid a dollar amount per member in the MCO program or MCO insurance. And it is then upon the award winner, i.e. the payer, to figure out how to provide care on those dollars, right? So it's kind of this responsibility of, you've accepted the contract, you've negotiated and bid, therefore you're making a commitment to us, MCO insurance company, that you're going to be able to provide quality care at this dollar amount. And what you end up finding out is exactly the situation that you alluded to, Aren, is that they start making cuts, because that is profit for them when they are able to provide it at a lower amount and create a larger margin or gap between the cost of care and what they're being paid per member. And so you get in this situation where it leaves a whole lot of gray about where they want to make cuts. And you get you get left exactly with what the Deshaun Morris pain and profit story became. So yeah, it's challenging to say the least, and we could do a whole nother episode on that alone. But Aren, that's all the time we really have for today. So I appreciate you taking some time and speaking with us and sharing some valuable insight about your experiences in healthcare.
Well, thanks for having me. It's been fun.